I'm Perry Hardy, along with Sarah and Joanna, another co-founder, and I'm so excited to introduce Annie tonight. She's a clinical social worker with the Utah Infertility Resource Center. She's based in Salt Lake City and has focused specifically on infertility in much of her practice as a clinician. Having her own personal experience with infertility, she knew early on in her career that she wanted to help others navigate their journey through family building. She has been with the Utah Infertility Resource Center for 4 years, and we are so grateful to have her here to go over some Infertility 101. And with that, I will hand it over to you, Annie.
Perfect. Thank you so much for having me. And this is not my first time, but in the last few weeks, I just learned about the Hive Collective, and what a great resource it is for women in the community. So thanks for doing that. And again, thank you for having me here. Infertility, as you mentioned, I've struggled with it personally, so it is something near and dear to my heart. I didn't realize kind of how difficult it could be to struggle with until I was in it myself. And so I feel, like you said, I knew when I was in graduate school and I was doing in vitro fertilization for the first time, I was like, oh my gosh, we need way more support for people dealing with infertility. So here I am now, and I've loved it. So hopefully I can give everybody listening here just the basics of infertility. I'm not a doctor, and I'm not going to pretend to be. But so of course, take what I say with that in mind. I have been trained through the American Society for Reproductive Medicine in their basics of infertility. So a lot of what I'm sharing with you is what I've learned from them. And it's a lot of information. So please ask questions if you need to, however you feel comfortable doing that. And yeah, we will get started. So let me see.
There is the chat option if you want to ask a question anonymously. Sarah can answer those questions Sarah can read those questions to Annie. And then if you want to ask a question yourself, feel free to unmute yourself and Annie can answer those.
Yes, perfect. Okay, let me do the screen sharing thing again. Oh, for some reason, it is being weird now. Don't mind us. Oh, it closed the tab. Anyways, let me tell you a little bit about Utah Infertility Resource Center while I get this pulled up again. So this was founded, Utah Infertility Resource Center was founded about 5 years ago, started by a group of women who were also struggling with infertility. And we're just kind of like, hey, there's like no education, no support out there available. So they decided to just go ahead and get something started. So they were doing support groups, just peer-led support groups from their living rooms in the beginning, and now it's expanded to where we offer counseling, these educational consultations. Before the pandemic, we were doing monthly events and seminars type things, as well as peer-led support groups with all sorts of different topics and located in all places over the state. So let's see, this should work now. Okay. Thanks for waiting for me. Ta-da. Okay. All right. So as I mentioned, being unable to get pregnant is super stressful. I thought this quote was a really good really described it well, what it's like to go through infertility. So being able to get pregnant, unable to get pregnant is one of the most stressful things a woman can go through. Most of us, until we start trying and failing to get pregnant, assume that if and when we want children, we'll have them. I kind of love the movie Mean Girls, because there's that part when they're all in health class and the gym teacher is like, if you have sex, you will get pregnant and you will die. And I'm just like, yeah, that's kind of what some of us have been taught in a sense. So it's really surprising when we can't get pregnant. So what is infertility? So how it's defined, it's a disease of the reproductive system, and defined by the failure to become pregnant or remain pregnant after 12 months of regular intercourse without contraceptives. If the female is over the age of 35, then it's reduced to 6 months. This also applies to a woman who experiences recurrent pregnancy loss. So multiple miscarriages, they kind of fall in the infertility category. It's kind of this big umbrella. So it's not just not being able to get pregnant, but being unable to maintain a pregnancy. And then there's a chart over there. You can kind of see everything that goes into having into creating a baby, basically. I remember doing one of my trainings with the American Society for Reproductive Medicine. I'm just like, oh my gosh, like it's a miracle that life has continued, because oh my gosh, there's so many things that have to happen: balanced hormones, functioning sexual organs, quality eggs and sperm, um, making sure anatomically everything's okay. It's really complicated. There's a lot that can go into it. So let's see. Oh, this doesn't want me to switch slides. There we go. So who does it affect? Infertility affects 1 in 8 couples. So if you think about all the people you know, whether it's yourself or a friend or family member, you know somebody who's struggled with infertility. And there's actually some studies that suggest the number could actually be quite a bit higher. And people are shocked to find out that it's often, it's pretty equal, between female factor and male factor. A lot of times it gets coined as a problem with the woman, like, oh, you're not pregnant, what's wrong with you? But actually it's really quite common for it to be a male factor. And as you can see, it's also really common for it to be combined factor, where there's issues with the male partner and the female partner. Then there's a little sliver, of situations that are unexplained, where they do all these tests and they just still can't figure out what's going on. Let's see. Okay, so male factor infertility, here's some of the basics of what can kind of go on with the male. So there can be anatomical issues, that can include like undescended testicles, varicoceles, that are like basically, what are they called? Oh my gosh, like varicose veins in the testicles that can cause problems. Physiological problems such as erectile dysfunction, or other issues with ejaculation. Problems in the semen, maybe there's not enough sperm, maybe there's low motility, or they're shaped funny, which we call poor morphology. So there's all kinds of issues there. Those are the most common ones with men. Then female factor is a whole other fun list. So some of the most common ones are polycystic ovarian syndrome, which you may have heard of, or PCOS, diminished ovarian reserve, which is when, you just don't have quite as many eggs as maybe someone would on average at your age, or premature ovarian failure. So does that make sense? So they run a bunch of tests and it's like, oh wow, you don't have as many eggs as someone your age ought to, or something like that. Sometimes it's um the egg quality is poor. Um, so, less likely to maintain a pregnancy or to even get pregnant, things like that. Fallopian tube abnormalities, sometimes they can be closed or there can be scar tissue stuck in there. Polyps, fibroids, endometriosis. Uterine septums can be an issue where there's actually something. It kind of looks like something dangling from the uterus. I heard someone describe it as like a, oh, I forgot what that thing in your throat is called, where that just hangs, you know? Um, yeah, so there can be issues there. There can also be issues with the cervix. And unfortunately, some of these issues there is not testing for yet. Endometriosis can only be diagnosed, like officially diagnosed through surgery. And doctors are not routinely recommending that anymore. They do for certain patients where they think it might be indicated, but again, it's not always recommended. Um, so those are just some of the main female factors that can contribute to infertility. Um, Other factors that can contribute, internal factors such as infections or diabetes, obesity, anything that can cause hormonal imbalances. There's a lot of research right now going into environmental factors. I know one of the clinics here was really into, figuring out how much the inversion affected fertility with women, men and women. So those are things to think about too. Then combined infertility results from a combination of male and female factors. Um, then, as I mentioned before, sometimes the usual tests results appear normal and there's no known cause for the infertility, and they call that unexplained infertility, which I actually see quite a bit in my practice. Then we also see a lot of secondary infertility, which is one that's not quite as understood as primary infertility. So, secondary infertility is defined as the inability to become pregnant after you've already had a previous pregnancy. So, maybe you've got one kid or two, and suddenly you are just not getting pregnant. You have no idea why. And we really try to reach out to men and women struggling with secondary infertility because it is highly misunderstood within the community. I think there's this general attitude that, oh, well, you've got a kid, so you're fine. What are you complaining about? When in actuality, it's really hard and really painful, and people going through that still need support. Then we have recurrent pregnancy loss. When a woman miscarries 2 or more times. And that's defined a woman whose pregnancy reaches at least 5 weeks beyond. So, yeah, those are kind of some of the other things we look at. So, what do you do when you are this person trying to get help, trying to get pregnant? And it's like, well, what do we do? A lot of people start with their OBGYN. And depending on your OBGYN, they can, offer quite a bit of help. I know personally with me, mine did some basic tests and everything, just some blood work and, found some things early on. But then after a few months, it was kind of like, okay, well, she just kind of sat me down and said, well, I'm past my knowledge of these things. It'd probably be best for you to look into a specialist. You do not need a referral to visit a specialist. They're typically called reproductive endocrinologists or infertility specialists. And what makes them different is they're basically OBGYNs, but they've gone through an extra 3 years of training. So they have really specific training in what goes into getting people pregnant, basically. And then you'll see there at the bottom, sometimes if there's male factor issues, they will refer, you might consult a urologist who specializes in infertility, and we do have a few of those in Utah, which not every state does apparently. So we actually get quite a few people from like Wyoming and Idaho coming out here to meet with our urologists that specialize in male infertility. And I can definitely go over some of the local clinics that are around here. So, what happens when you first call a reproductive endocrinologist? So, what they'll do is they'll want to perform some basic tests. Usually, they'll want to check for sperm quality, egg quality. They'll want to check female anatomy and ovulatory function in these tests. So, and how do they do that? So, for the male partner, I think the guys get the easy part. They, it's a semen analysis. There again, they're checking for morphology, the count, and their motility, so their ability to move. Sometimes they do a sperm penetration assay, which is, I don't hear it as commonly nowadays. It's kind of known as the hamster test, but they basically, they're trying to see how well a sperm can penetrate the wall of an egg by using hamster eggs. So they just put them in a petri dish and like, okay, how well can these sperm penetrate these eggs? Which is, I know that sounds super freaky and everything, but can give helpful information if it's like, oh yeah, okay, this sperm is not able to break through the wall of the egg. Then, if indicated, they'll perform other blood tests. So, they'll check thyroid, low thyroid issues can affect sperm production, things like that. So, that's kind of what happens with the guy. For the female partner, it's a little bit more invasive. So, you usually start with blood work. And when you're getting your blood work done, they often check for your AMH levels, or the anti-Müllerian hormone. It's a protein hormone that can indicate your ovarian reserve, or how many eggs are there. It's not an exactly accurate number, but it can give them a good guess. And then they check follicle stimulating hormone. And that checks, it's a pituitary hormone that stimulates growth of ovarian follicles and helps the eggs to mature. They might also check, some of your estrogen, progesterone, LH levels, testosterone, just anything you can think of. Thyroid, there's all kinds of things. Low thyroid especially can be a huge factor with recurrent miscarriages. Then a lot of times there's ultrasounds, and there's several different kinds. So one of the first ones is to do an antral follicle count. So they'll kind of say like, okay, when your period starts, call us, and then we'll have you come in a few days and we'll check your follicles. So you come in when you're on your period and they check and see what your follicles are doing. Then there's a hysterosalpingogram, which is where they inject dye. They put you under an X-ray machine type thing, and they insert dye into the uterus, and they watch to see if the dye flows out of the fallopian tubes. It's a way to check if the fallopian tubes are open or not. And it's, having personal experience with it, it's not the most comfortable procedure. But if you're lucky, your doctor will give you a Valium or something like that. So that helps. Then there's sonohysterogram, which is, they call it a water ultrasound too. So it's really similar to the hysterosalpingogram, but they're not looking at the tubes. They're just looking at the structure of the uterus. So that can let them know if polyps, fibroids, things like that. Okay, and I'm talking more about this than I want to. Then for the couple, there's genetic testing. It can be done before any treatments are done, just to see if either partner has any chromosomal abnormalities or genetic factors affecting fertility. Then if you've done in vitro fertilization, you can also have your embryos tested for any abnormalities too. And I can get in, if anybody has questions about that, I can get more into that. I do want to make sure I get into treatments. Um, so yeah, there's a ton of treatments available. So I think that's one of the most stressful things when you start seeing a reproductive endocrinologist. It's like, okay, what are they going to make me do? Are they just going to make me jump right to in vitro fertilization? And what is that? So I'll kind of go through some of the basics of the different treatments out there. Um, and I didn't really include costs on these treatments just because it can vary so much from individual and clinic. But I'll try to give you guys kind of a brief overview as far as costs goes. So typically, depending on what the doctors find, they, might start you on medications, whether they're oral or injectable. So that's kind of, like Clomid, um, those types of drugs you hear about. Sometimes the male partner will take them because it can improve sperm quality. There's also surgeries. So sometimes the man, he might have a variocele and other anatomical issues. Sometimes a laparoscopy, if that's indicated on the woman, if it's suspected she has endometriosis, or they find on the HSG test that there is some scar tissue, then they might proceed with a laparoscopy. I'm going to skip that one. Then the common procedures, intrauterine insemination. So this is when there's kind of a nice little picture here. This one is the less invasive of the big treatments, I call it. So what you're doing is you're just injecting sperm into the uterus through a catheter. So you're letting the woman ovulate, she's on some sort of ovarian stimulating drugs to get a few follicles growing. And after she ovulates, they will inject the sperm with a catheter. So that's what that is. And that typically, I don't want to give a false number for how much that costs. I've heard of IUI costing anywhere between like $800 and, a couple thousand. So a little less expensive of some of the treatments. There's testicular sperm extraction. So if there's a severe issue with sperm count or sperm motility or whatever, they can go in and perform a surgery to go in and microscopically find sperm to use for treatments. So that's an option too. Usually that's used with IVF, or you can see there's a couple other procedures there too. So I'll explain those as well. So then there's in vitro fertilization, right? And this one is a little complicated, and that's why it gets so expensive, is because it's kind of complicated. What you're doing is you're hyperstimulating a woman's ovaries so that she's growing multiple follicles. I mean, each month we only grow one follicle. And when you're doing in vitro fertilization, we're trying to grow multiple. So I literally remember when I was going through it, my ovaries, they're about the size of what did they tell me? I don't know, like an almond, I think is what they said. And then when I was going through in vitro, I mean, they were like tennis ball sized, each of them, because they were just so overstimulated. So it's not super pleasant, but your goal, the plan is, to go in and harvest all of the eggs that are mature and remove them from the woman's body. And then the eggs fertilize with the sperm outside the woman's body. So I know, super complicated. So they will, oftentimes when you're doing this, the woman is getting blood draws and ultrasounds done, 3 times a week, often, because they just want to make sure you're reacting to the drugs okay, need to see if there's any adjustments that need to get made, all kinds of things. So sometimes the eggs fertilize just by putting them in a petri dish with the sperm, and they'll just let them sit there. They'll check the next day and see how many eggs fertilized. However, when there's issues with sperm quality, a lot of times there's another procedure that embryologists will use called intracytoplasmic sperm injection. And it's literally like what you see in that picture there. And, or we call it ICSI for short, because that's a little bit easier. But so they're literally like manually taking the sperm and injecting them into an egg to fertilize it. So again, that's used a lot with in vitro when there are issues with semen or with sperm. I know sometimes it's used for women, if like say the woman doesn't have as many eggs as they expected, then it's like, okay, well, we've got to fertilize as many eggs as we can, so they decide to do that. And I had an embryologist, like, it's so weird. He described it as literally being like a video game, a microscopic video game, where it's like, yep, we have one controller bringing the sperm over to the egg, and it's really cool. And I'm just like, yeah, okay, that sounds interesting. Crazy what they can do. So then there's also frozen embryo transfer. So a lot of times when a woman goes through in vitro fertilization, sometimes she has extra embryos. And obviously, like, if you get, say, 10 embryos or 10 eggs that fertilize and, make it to transfer, you're not going to transfer 10 embryos, right? So the ones I should have said with in vitro, you typically wait until day 5. You let your embryos grow for 5 days, and then you transfer 1 or 2 back into the uterus. So with the frozen embryo transfer, these are leftover embryos from doing in vitro. So you can thaw them and use them for a future treatment, which is nice. It makes frozen embryo transfers a little bit less expensive than doing a full in vitro cycle, because you don't have to do the egg retrieval and everything. So people often ask me, what's the typical cost of in vitro fertilization? And again, it depends totally on the woman and the clinic. I would say on average, it's around $15,000, $16,000. It's pretty expensive. And unfortunately, we don't have, not many companies offer insurance coverage for treatments. So that can be a real barrier and a huge stressor to women going through these. So, and then quickly, I'll just mention third-party reproduction. So, that's when you use reproductive material from a donor, someone outside yourself and your partner, to have a baby. And there's a few different methods available. So there's the egg donor option, sperm donor, embryo donation, and then there's gestational surrogacy. Oh, there we go. So sperm donor, I think we all kind of know what that one is. Obviously a separate male from the relationship, you use their donor sperm. Egg donation, usually that's when a woman who will go through the in vitro process and donate her eggs through that. And then typically the male partner sperm are used with this donor eggs, I should say. There's embryo donation as well. So if people have frozen embryos that they're not going to use, oftentimes they will put them up for donation or offer them to be donated. So that's an option as well. If a couple can't afford to do in vitro fertilization, but wants to experience pregnancy, this can be a great option for those who really want that experience. Gestational carrier. So it's a woman who has no relation. I shouldn't say no relation, but woman whose gametes are not being used, carries the baby to term and gives birth. Surrogacy, traditional surrogacy is not legal, or at least there's no current legal protections. Just because the way it's set up, it gets a little complicated. So a woman is inseminated with the sperm of a man who is not her partner. So you're using the woman's eggs, the woman who is also carrying the baby. So no current legal protections for them. So not recommended. Um, anyways, local infertility clinics, briefly, we recommend going to clinic, just researching and finding one that works best for you. Sometimes you might need to visit one or two um, to really feel like you've got a good fit. So we recommend finding SART, or Society for Assisted Reproductive Technology certified clinics, just because they're held to a certain standard. So that all the doctors you're working with are reproductive endocrinologists and have been specially trained. So you'll see a list there: Utah Center for Reproductive Medicine, which is based up at the University of Utah; Utah Fertility Center, which is in Pleasant Grove, Murray, and Ogden; Reproductive Care Center there in Sandy and Pleasant Grove; and then Conceptions Fertility Center is a newer one. They're down in Provo, and they actually might have their SART certification by now, but I'm not sure. But also fabulous doctor. So again, insurance companies typically do not cover fertility treatments. So you kind of have to dig a little bit deeper with your insurance company to find out, will they cover, some insurance companies will cover diagnostic tests. And, so this is a huge barrier for people trying to build their families, is cost. It's not uncommon for a first round of IVF to not work. And so then, if you have to do it 2 or 3 times, suddenly you've spent, $50,000 to $60,000 out of pocket to start your family. So it can be really tricky. There are different organizations out there that provide grants or other supports. The different clinics also provide different financial options as well. So if anybody has questions about that, I can go into it. So then there's also treatment support, holistic health. There's natural family planning information out there. So, finding books and resources about tracking your cycle, I think that can be very empowering and helpful, because there's a lot of things about our bodies we don't know. There's acupuncturists trained in fertility treatments. So it's really common actually for people who are going through in vitro fertilization to have an acupuncturist come and give them a treatment before their egg retrieval, and then maybe come and do one before their embryo transfer. So that's really popular. There's yoga geared towards fertility. There's Mercier therapy, which is a special type of pelvic massage to help with the reproductive organs. Meditation or mindfulness, essential oils, diet, supplements, these can all be really helpful, at least in supporting you through your treatments. So we know oh gosh, I've been talking a long time. I'll be careful about how much time I spend talking about this stuff. Well, we know that emotional support is huge and so important with infertility. Just because, Gal, I remember before I went through it, and talking to friends who were struggling with infertility, and I just didn't get it. I was kind of like, oh, well, that's sad, but you can adopt, or there's other things you can do. Then I went through it, and oh man, it was a huge blow to my self-esteem, my sense of self-worth, and just my feelings of purpose in my life. So it's so important to find emotional support. There's actually been studies done where they've found that women going through fertility treatments have the same stress levels as women going through cancer treatments. So it's pretty significant what can happen and what can go on. And that's not just to say women go through that. Men definitely have strong emotional reactions too. Often it's really common for the partners to go through different stages of grief and feelings at different times. So just, we really encourage couples to talk with one another about what they're going through. So let's see. Yeah, it's good to find emotional support through support groups or counselors or other professionals to help with those things. Sometimes if you ask your doctor, they can guide you to someone. So then there's definitely grief and loss associated with fertility treatments and even with adoption. So you might have a failed cycle where you transfer an embryo and it just doesn't work. That's hard to go through. A chemical pregnancy, which is the loss of a very early pregnancy. So you had a positive pregnancy test, but you were not able to see the baby alive on an ultrasound. There's an ectopic pregnancy, which is really devastating, after getting a positive pregnancy test and then finding out that you can't carry the pregnancy to term. That can be devastating and often results in the loss of a fallopian tube, which adds another layer of stress. Then, of course, there's miscarriage, stillbirth, neonatal infant death, loss or death of embryos. I've heard, stories about women who, it's like, oh yeah, we got 5 eggs, they're sitting in this petri dish, we're waiting to see how many make it till day 5 and what we can transfer, what we can freeze, and none of them make it, which is devastating. To have to feel like you have to go through all that again, or you wonder, should I go through all that again? Then there's also failed adoption. So when an adoption falls through and you've been planning that for months, years even, that can be especially difficult. So it often impacts every relationship you have with your spouse, your partner, friends, siblings, parents. So, most women I talk to just say like, oh my gosh, I can't even go to family parties anymore, or I can't go to baby showers. It's a huge impact on their social life. It's a very lonely and isolating place to be, struggling with infertility, because a lot of your friends are having kids, you're not, and it's hard. It feels really lonely. So finding support, we offer free support groups, and I can give you more information about those, but they're typically based by county. So we have like a Utah County one, Salt Lake County, Weber Davis, and then we also have a few specialty ones. We have a pregnancy and parenting group after infertility, just because we know it's really common, or women who go through infertility have a much higher risk of struggling with postpartum depression afterwards. So we made the pregnancy and parenting support group to help with that specifically. We know it's kind of its own ball game there. So there's a list, a teeny tiny little words list of some of our different support groups. But again, I can share this information with you at the end. We also have counseling, and we offer it on a sliding fee scale. Unfortunately, we don't take insurance at this time. We hope we get to that place at some point. Well, actually, that might not be true. I think we just barely started accepting a couple of insurance plans, but I'm not exactly sure.
We do take a couple.
Do we? Oh,
Yeah.
Morgan, hello.
Hi.
Yeah.
Hi.
So, but we do, we have a list of resources. So if you want to go through your insurance, we can definitely refer you out. The Healing Group is one of those great resources that offers that infertility counseling. Group therapy, every now and then we offer some group therapy. We have a yoga therapy group we've done a couple of times that people have loved. So, and I know the Healing Group as well offers some group as well. So, okay, I want to make sure we leave a few minutes for adoption, right? So when you decide, I don't really want to go down the treatment route, or it's not working or something, this is a whole new world for sure. So, we all know what adoption is, defined as the legal transfer of parental rights and responsibilities from a child's birth parents or other guardian to an adoptive parent or parents. Um, there's quite a few people involved with making this happen. So I'll just kind of go over the steps, the different types of adoption, and then the steps required. So, really quickly, one of the big losses of infertility is childlessness, of course. And we really emphasize with couples or individuals going through adoption that adoption does not cure the infertility factor. It does cure the childlessness, but the infertility often lingers. Those issues of self-worth and grief often linger for adoptive parents, and which is okay. That's normal. We just like to emphasize that it's important for couples to deal with feelings of grief and loss before they adopt, so they can optimize the chance for bonding and building attachment with their adopted child. So we have open versus closed adoption. And honestly, I would say like 95% of adoptions are open now, meaning that the adoptive parents and the birth parents and the child, they're all remain in contact with each other. So the child has some relationship with the birth parent. This scares a lot of parents at first, or potential parents, worried about, oh, well, what if the birth parent tries to interfere? But they do this because their research is finding that the best outcomes come from this type of arrangement. The best outcomes for the adoptive child and for the birth parents, when there can be some sort of relationship um, available. And it looks different between each family. So some families, it's like, oh yeah, we do a FaceTime call once a month with the birth parents, because they live out of state. Or some families, it's like, oh my gosh, we have them over for birthday parties and sometimes Sunday dinners. Like, it just looks different for everyone. So you kind of decide with your caseworker and their caseworker what works best for you and for the kids, and every situation is different. So, adoption procedure. The first thing you'll do is complete a home study. So, I don't know how many of you have heard of that, but basically, it's when a caseworker or a social worker comes into your house. It sounds a lot scarier than it is, but they basically just come and do make sure, oh yeah, this looks like a home that a child could safely grow up in. Safe, and by safety I mean emotionally, physically, psychologically, all of that. So it does include background checks and medical screenings, and a home inspection. So yeah, it sounds super scary. People I've talked to say, okay, yeah, it sounds scary. It usually doesn't end up being as scary as it is. Then you'll kind of create your little profile. You'll create a profile as an adoptive parent, and you'll look at prospective birth parents' profiles. It's kind of this, it's almost like match.com, but with kids, which sounds awful, or with birth parents, I should say. So you're kind of advertising yourself and like, yeah, we want you to place your child with us. Like, we would be such good parents. Then you're connecting with a birth parent to an adoptive parent. You're trying to connect and get things set up, making sure you get emotional and other support as needed throughout this process. Then your caseworkers also help with that communication between the birth parent and yourselves once a match has been made. So it's really common to talk to a few different birth parents before they say, like, okay, yeah, they want to place their child for adoption with your family. So it can take a lot of time, which is unfortunate. I hear of some people waiting months. I hear of some people waiting years. It just depends. So then there's the facilitating of adoption procedures at the time of birth. And then at the hospital, there's a relinquishment of guardianship. I think it's in Utah, I think it's 24 hours after the birth has happened. Um, and then the official placing of the child with the adopted family happens at the hospital as well. Again, that 24 hours after. Then for the first 6 months, at least this is how it is in the state of Utah, there's some placement visits where your social worker just comes just to make sure it's a good fit all around. So the adoption is actually not final until after 6 months. And people think, like, oh, is that because they want to take, the birth mom wants to take the baby back? And no, that's not what it is. It really is just they want to make sure, like, once the birth parent signs those relinquishment papers, they cannot take the child back. But they like to give a 6-month window of time to make sure that the placement is what's best for the child and for you as the adoptive parent. So you can go through an agency or you can do it privately. And since I'm on agency right now, I will just briefly explain that. When you go through an agency, it's kind of like when you go to a restaurant with an all included buffet. You have your desserts, your entrees, your appetizers. So, when you go through an adoption agency, you have your lawyers, your social workers, everything provided for you, which can be really nice and alleviate a lot of stress. However, it is a bit more expensive. It's typically $30,000 to $60,000. So it adds up really fast, but again, can alleviate a ton of stress. When you go through private adoption, the services are not all provided through the agency. So it's kind of more of an a la carte experience. You're kind of left on your own to find a social worker, find a lawyer, and other professionals you need. But the costs tend to be a lot lower. So usually starting around $5,000 to $6,000. But yeah, a bit more, it's more work on the part of the adoptive parents. International adoption, I don't see many people doing these days just because it can get so complicated. You have to follow the laws of the country you're adopting from and the United States. So I think I actually have a neighbor who works in Haiti, and one of the really common, one of the popular agencies people go through here for international adoption is Wasatch Adoptions. And let's see, I know people trying to adopt through them, they're waiting years for their child to get here. So it can be rough. It can be great when it works out. I'm not trying to deter anyone from that, but it can get complicated really fast. So adoption through the state, you can adopt through foster care, or adopt a waiting child. So adopting a waiting child, usually this is a parent who's had their child with them for several years, or sometimes it's only several months, and then they decide to place them for adoption. So then they go into the foster care system usually, and then they try to find someone who, a foster parent who also wants to adopt to take these kids. Then there's foster to adopt. Again, where the family fosters a child where the parental rights of the birth parents have been terminated, at least temporarily. And this can be a great option as well. It's, little to no cost. Often you're getting stipends to be a foster parent. However, the emotional roller coaster can be very difficult. Most children, the goal of foster care is to reunite the child with their birth parents. So it's only about 1 out of 3 kids that actually go on to be adopted through the foster care system. So again, it can be a really emotional journey. But I know several people who have done it, and they love it. So there is a lot of training required. Well, not a lot, but there is in-person training. I can't remember exactly how many hours are required. So there,
Annie,
Yeah.
Oh, perfect. Okay. This is because I just wanted to leave a few minutes for
Yeah.
questions, and I'm super mindful of time, but you have so much to share. So
I know. I am
thank
done.
you so much. Oh my gosh, perfect timing.
And I feel bad because I remember telling you this would only take like a half hour. And then I'm like, oh my gosh.
Don't feel bad. I mean, this is so, it's very, very interesting. I do have a few questions, but it looks like we can go to the website, Utah Infertility Resources Center.org
Yes.
for resources. So
So when
that's
you
great.
click on that website, so Morgan, you might have to answer this question for me. It looks like you need to opt in to be on our mailing list to get
Okay.
access to the list of we have like a huge 10-page list of
Yeah. Well,
a bunch
that's
of
great.
different resources.
And we would love to share a few of the resources that you shared with our members too. But I had a question come through the chat, and I just wanted to see what you thought. Since you had mentioned in your intro that you also had struggled with infertility, do you have, and you have children now? Is that, yeah. So what's something that you wish that you had known prior to going through it? Just having that hindsight. Like what's like something you wish you knew?
I Oh, that's a good question. Um, I think I wish I knew I wasn't alone
Yeah.
and that I wish somebody told me there was nothing wrong with me because I think I personalized it so much and it's just like, okay, well, yeah, this is happening for a reason. There must be something I'm doing wrong, or whereas no, that's not what it is, and I wasn't alone. This is actually more common than people realize, because it's super isolating. You don't want to talk about it because you're embarrassed, you're ashamed. And
Mhm.
so having people, I mean, I had support, but I wish earlier on
Mhm.
someone had just like, hey, you're not alone. I'm struggling with this too.
Mhm. And what role does stress play in infertility? I can think of a couple people I know that were in the IVF process and in the meantime also got pregnant.
Yeah.
So
Yeah. So
what is there any like nugget on that, or is it just it was their time? I don't
no,
know.
that's a really good question. So we do know, at least the studies that are out there, there is some correlation between stress and infertility. However, unfortunately, it's just really hard to conclude what the correlation is and how strong it is. Um, and I like
Mhm.
to tell couples, well, and their doctors will often tell them, like, yeah, you've got maybe a 60% chance of getting pregnant with in vitro fertilization, maybe a 20% chance with insemination, and then maybe like a 5% chance on your own. So there's still the possibility of getting pregnant um, on your own. I think the fertility treatments with them, you don't have to feel like you don't have to wait as long with them. But
Mhm.
yeah, I do hear stories of that. Women who go on who do treatments but then end up getting pregnant on their own.
Mhm. Does anyone else have a question for Annie? Feel free to unmute yourself if you have a question. If not, I have one last question
Okay.
that I wanted to give an opportunity. Um, I guess my question was there was a funny meme on there that said, if you tell me, this happened for a reason, I might slap you because that might happen for a reason.
Yes.
And it made me chuckle. And one of the things that we do at Hive is we try and educate on what not to say when someone's going through these hard times. Do you have anything personally or anything that you've seen aside from like, it's meant to be, or, hopefully we know the cliche, but just a nugget of wisdom to leave us with?
Yes. So that one, oh, it must be meant to be, or there's a reason for everything. I think also the just relax, um, the, like, oh, just relax, it'll be okay, it'll happen. When, we try to tell people you wouldn't say that to someone with diabetes or with cancer. Whereas with
Mhm.
infertility, there is a real physiological thing going on. And we do know stress plays a role, but that's kind of why we try to get away from that. Well, yeah, stress plays a role, but we don't know how much. And we don't like to say it's often the sole factor of someone's infertility. So yeah, I think just if you're supporting someone going through infertility, just keeping that in mind, that it is really stressful and scary, and just validating that, just, wow, this must be so hard for you. I can't imagine going through that. Or if you are the person going through infertility, trying to be assertive and advocate for yourself, just, well, yeah, I'm doing my best to relax, but actually, I've done some tests and there could be some real issues going on. Infertility is a real disease. The American Society for Disabilities recognizes it as a disability. So, yeah.
That's really insightful. Thank you so much. And then we had a question from Claire, and she's looking for some tips to get an appointment. She's having a really hard time.
Sure.
Do you have any like secret hotlines or any,
I wish we had secret hotlines. That would be so great. So if she goes, or if anyone goes to our website, just the Utah Infertility Resource Center.org, you can find a list of all of our services. And actually on there, if you go to, I think the tab is services, you click on counseling, and you can submit a form to have someone call you to set up a counseling appointment.
What about with a doctor? Do you have a doctor through there too? I think that
so if you sign up for this list, so if you go to this link and sign up for our mailing list, you will get a link to doctors available. I should have
find that they're pretty booked out. Like, is a couple months wait
depends.
Typical.
And COVID has definitely thrown everyone for a loop. So some clinics are like playing catch up with treatments, but yeah, it just depends. Typically, I say, unless there's a specific doctor you want to get into, typically I just tell people call and see who's available and who can get you in the soonest. So when you do that, usually there's someone at a clinic that can get you in within a couple of weeks. But again, it depends on the clinic. Does that answer your question?
Claire, does that answer your question? If she wants to unmute. I think so. But
sorry, I was on mute. Yeah, I called, I went to your website and I called a bunch of places. I guess because of COVID, I couldn't get an appointment until late February, and even then they weren't sure. And so I just went down a list, and I think it's because a lot of people, they're reducing the number of appointments they have available, and then maybe because there's like a COVID baby boom, I don't know. It's really hard to get an appointment. So
that's so frustrating. Well, and I should have put my email on here, but if you would like to email me personally, I can get you some of their contact information and see who we can, if I know of a doctor who's more available. But my email, for anybody who wants it, it's just Annie, ANNIE, at uirc.info. So please feel free to email me with any questions. I do know there are clinics playing catch up, but yeah, that is so crazy. Like, COVID's really thrown everything off, right? Just ready to be done.
Well, thank you so much.
You're welcome.
Anyone have anything else that is burning? Well, we really appreciate it, and we will send out your some resources with this recording, and we're just wishing everyone, the best of luck. And thank you so much, Annie. We really
thank you for having me. Thank you for staying with me for all of that information.
Yes. Well, no, it was really educational. So, or at least for me it was. So thank you so much. And I'll put I'll put your email address in here too for everyone else. Is that right? Yeah.
Perfect.
Oh, maybe that's here. Okay. Okay. Well, everyone have a really nice evening. Happy holiday. And thank you so much for your Hive support. We really, we wouldn't be here if it wasn't for you all. So thank you very much. And we'll look forward to working with you in 2021.
Perfect. Thank you so much.
All right. Thank you. Have a good night. Good night.